Okay, now before we get into all our presentations from our wonderful speakers tonight, we want to acknowledge that even though this is a virtual event, that our organizers are located on Treaty 6 land, which is the ancestral land of many Indigenous people, including Cree, Saulteaux, Blackfoot, Métis, and Nakota Sioux. And we want to recognize that the heritage and traditions that continue to this day, which enrich our communities, as well as the history of colonial violence that continues to oppress these Indigenous communities. Okay, so without further ado, hello. I want to thank you all so much for attending. I'm so excited to have you all here. My name's Emily. I'm going to be your host for this evening. And I am a summer student working on Tele-Rehab 2.0. So mostly I do communications and outreach kind of work. And I'm just so happy to be part of a project which is doing such innovative work in our healthcare system. So tonight we want to use this webinar to tell you more about the impacts of our project. At the beginning of our project, we were faced kind of with reluctance from both patients and clinicians who regarded in-person appointments to be kind of the standard or the superior system. But then COVID hit, and with the pandemic, telehealth has become the only option and has become commonplace. And through that, it's shown people the many benefits of connecting with your doctor virtually. So since then, we've learned a lot about the positives and about the challenges of the telehealth that's going on right now, like phone calls and video calls. And so for us, this is where we come in as Tele-Rehab 2.0, because all this work we did pre-pandemic, before virtual health became kind of mainstream, has paid off and has allowed us to kind of address some of these challenges to make tele-rehab care really painless and stress-free and really precise. So during this webinar, you're going to hear from a couple different speakers. You're going to hear from our project coordinator, from a hub clinician, a rural clinician, and even a patient about their experiences with our project. And so we hope that hearing from these individuals will really highlight the successes and the need for our project to continue in order to work towards equitable healthcare for all Albertans. And so to begin, to kick off the webinar, I want to introduce Emily, who is our lovely project coordinator, and she's worked so tirelessly to get the project to where it is now. She is our resident grant writer, our administrative whiz, and your go-to gal for all things communications. And she has also, most recently, she's been attending all of our trials to observe and support the clinicians in any way they need. All right, go ahead, Emily.
Wow, what an introduction. Thank you so much, Emily. And hi, everybody, welcome. Thank you so much for joining us this evening. It's really exciting to see so many people from across Alberta and even from across the world who have interest in our project. So like Emily said, my name is also Emily, which has not been at all confusing to our team. And I am, as mentioned, I am the project coordinator for Tele-Rehab 2.0. So I'm going to share with you guys a little bit about how our project works, some of the issues that we're trying to solve, and how Tele-Rehab 2.0 compares to Tele-Rehab 1.0, which is the term that we're using for like basic telehealth through phone or video call. Next slide, please.
There you go.
There we go. So after 19 months of preparation, we finally started our community trials at the end of July. It's definitely early days so far. We've only seen 16 patients to date, but we are honestly blown away by the success of the project and by the ability of our our hub clinicians, our specialist clinicians, to conduct these really complex assessments and treatments while their patients are literally hundreds of kilometers away from them. Next slide, please.
There you go.
I'm sure most of you already know this, but just to make sure we're all on the same page, Tele-Rehab 2.0 is a pilot project. And because of that, we're only focusing our efforts right now on 4 areas of rehabilitation. So those are wheelchair and special seating assessments, hip and knee post-arthroplasty or replacement follow-ups, severe shoulder pain assessments, and then vestibular and balance issues. Next slide. So the focus of our project is on protocol and technology development. We weren't trying to reinvent the wheel here about how clinicians run these assessments, but we wanted to focus on a protocol that was consistent for virtual health. And so over the 19 months we had of preparation, we had a lot of consultations with clinical experts to sort of map out all of the information that they need to see in order to actually get the information for these assessments. And this resulted in the creation of our storyboards. So our storyboards are still being adjusted as we see real patients, but they have been really critical just for guiding and really useful for guiding the assessments for both the local clinician here in Edmonton and the remote clinician in one of our remote sites. We've also been working really hard to develop and source different technologies that will help support virtual assessments. So right now in our remote sites, we have a desktop computer on a cart, and the computer houses a couple of different softwares that we use for our assessments. So one of those is it captures video for our vestibular goggles, and then the other one is a markerless motion capture system called Kinetisense. The cart also has a scanner for scanning any like consent forms or patient information forms, a normal web camera, and then a 3D camera that we use for the Kinetisense. And also in the remote site, we have the double robot, which is a self-propelled telepresence robot. It basically just looks like an iPad on a stick with wheels, but it does a lot more than you would think. And also there's like I mentioned, the vestibular goggles. But we'll talk a little bit more about the tech in a minute. Next slide. But I want to tell you guys a little bit about what an actual tele-rehab assessment looks like. So right now, they start off with a lot of boring paperwork, but the actual assessment begins with introduction so that the specialist clinician can meet the patient for the first time. And they also go through a little bit of background. So the specialist does actually receive a basic patient history through intake, but this often results in them asking or having more questions. So we have a little bit of time at the beginning to talk through these questions, and it's also the time for the specialist to start building a relationship with the patient so they can have trust in them and trust in the judgments that they're making on their health and their recovery. And it's actually really fascinating to watch the way that our clinicians are able to do this virtually, whether it's like through jokes or through explaining like what their education is or what their experience is. It's really cool the way that we're able to connect virtually. So then once this conversation piece is done, the specialist starts to guide the local physio and the patient through a bunch of measurements or tests for assessment. Some of these are visual only. For example, you just look at the way the scapula moves for a shoulder assessment. But some of these are, the data is captured through some of the softwares that we have. For example, the Kinetisense, the markerless motion capture technology, can record the way that you sway when you're balancing, when you're just standing with your eyes open or eyes closed. It can also track your gait when you're walking. And we're working on perfecting with this company a way to capture range of motion angle data. So it's not quite there yet, but we're really optimistic that it will be really effective by the end of the project. And also the vestibular goggles, they let us have a really close look at the patient's eyes while they're in darkness. So they don't see anything, but we can see how the eye moves. And this is really critical for diagnosis of different vestibular conditions. And so all of this information is streamed live through Zoom for Health, either through screen sharing or just the regular webcam. And it's also streamed live through the double so that the hub clinician can move the double around on their own and get sort of the angle that they need to see. And then also the webcam is on a tripod. So if the remote clinician needs to move that around a little bit so that the hub clinician can see properly, then that can be done as well. Sometimes, and mostly just with our vestibular clients, we can do like a treatment remotely. And so that once that is done and once all of the assessment pieces are completed, then the whole team sits back and has a chat, and they chat about what they saw. We answer any questions that the patient might have. They make a plan. The specialist makes all kinds of recommendations for the future of treatment for the patient, like explains to them how long they should expect their recovery to take in some situations, I mean. Essentially what's happening with our assessments is the specialist discharges the patient back to the local clinician or the remote clinician for all of the care in the interim. So we have like our initial assessment, and then all of the treatment and care happening between that and any follow-ups is the responsibility of the remote clinician. And that's actually really important for continuity of care. So the fact that the remote clinician is in the room with the patient and the specialist virtually means that they have a much more of a full picture of the health of the patient, and it's really interesting. But as Emily mentioned, I've been sitting in on all of these assessments, and as an observer, I think the most incredible part to me so far is how well these clinicians, and most of whom I've never met before these assessments, they're able to become this collaborative unit and work together almost flawlessly right from the very first assessment. It's like really a testament to how well our clinicians are able to collaborate when they're given this opportunity. So we'll go to the next slide now. I know that a lot of people who are registered for the webinar are healthcare professionals, or at least their emails were from Alberta Health Services. So I made a little bit of inference there. But for those of you who don't work in healthcare, there is a movement on right now to sort of include the patient voice and the patient perspective in both research and in care. And this is really important because ultimately, it's the patients who are impacted first and foremost by the decisions that we make as healthcare professionals. And so in line with that, this summer we interviewed a series of patients. We actually posted them on the blog on our website if you ever want to check them out. But we interviewed patients about their experiences with healthcare and virtual health, not Tele-Rehab in particular, but just telehealth, because we wanted to hear what it was like for them. Actually, if any of you were able to come to our last webinar, we had one of those family members, Dana Nagel, attend. And if you were there, you will not have forgotten what she shared about what her family has gone through in order to get her kids the care that they need. Dana shared that the days that they had an appointment, she was leaving for work at 4 o'clock in the morning, working until, like 10 or 11, leaving to go to the city to meet her parents with the kids there at the hospital, and then staying at the hospital for however many hours it took to get through the appointments, coming home, and then going back to work from home, working until midnight. And all of this just to get the kids to the appointment, because she, both she and her husband had to work full time to afford all of the care that they needed, all that stuff. And Dana and her family live in Leduc, I think. That's like only an hour from the university hospital. And this summer we talked to patients who lived, also an hour away, but also 3 hours away or 5 hours away, or even more than that. And all of them shared what a burden it is for them to come to Edmonton for their treatment. This could be cost of travel, the pain or discomfort of sitting in a vehicle for that long of time, which can actually, if they're coming for an assessment of some kind, it can actually invalidate the assessment because the swelling will be different, or they'll be in so much pain that they can't move the way that they can normally move. And also it can be really dangerous to travel the highways in Alberta during the winter. And so our project is sort of a way to mitigate a lot of these issues for patients and to reduce the risk to them. You still have to come to a clinic, but it's your local clinic, which is for most people a heck of a lot closer than coming all the way to Edmonton. And there is a person in the room with you to provide you support and to keep you safe. We'll go to the next slide. But patients did also share, issues and problems that they've had with telehealth. I mean, the way that telehealth took off with COVID was that most people were getting care while they were in their own homes. And that was really good in a lot of ways, but really not good in a lot of other ways. There's a lot of burden on patients to have equipment and to buy equipment, to have good internet, all that sort of stuff. But patients shared with us more specific issues that they had as well. We talked to one woman who connected with her doctor via phone, and she really felt disconnected. She really didn't feel a personal connection with her doctor at all. But with Tele-Rehab, we do get that personal connection because, not only with the double, which actually has this really cool effect of making it feel like the person is right there with you. People actually treat the double like it's a person and will make space for it in a circle and stuff like that. So that telepresence really counts for a lot. But just being able to see the person with that, like on the computer screen and also on the double screen, means that you can see their facial expressions, see them demonstrate things if they need to, and just really make you feel much more cared for. The same patient actually had to go out and buy a new cell phone to have her doctor's appointment. And like I said, like that's a big burden on patients to ask them to have the funds to buy this equipment so that they can get their healthcare. And so our project solves that because the clinic has the equipment. And for this project, we have supplied all of the equipment to the clinic, so there's no cost burden on the clinics. And so the patient just has to come to the clinic. They don't have to worry about getting proper Wi-Fi or anything. And so that's, a really big way to solve that. And then, other patients complained about trouble just with tech, with troubleshooting, with tech not working the way they want it to. And they don't have the support of the clinician for that because the clinician can't connect with them if the tech's not working. So even if the clinician could support them, they can't because whatever program they're using isn't working. They can't talk to each other. So we can help with that as well because there's a clinician in the room with you who is more familiar with the tech. And right now, like with the trials we're having right now, I am also there to support with tech issues, which is sort of the main reason that I'm showing up to these. So we'll go to the next slide. Because there actually are issues with Tele-Rehab 2.0. We don't have it all figured out yet. And the major issue we've had so far is actually bandwidth. So just the capacity of the Wi-Fi the capacity of the internet in general to handle all the information that we're transferring. Because we have 2 simultaneous video streams going for this project. It's a lot of space. And also a lot of the rural clinics that we're working in are not actually equipped with Wi-Fi at all. So we were able to overcome that particular hurdle by using it's called a Tele Smart Hub or something. And it's basically just like a giant hotspot for to get bigger area coverage but it's using cell towers. But that creates its own problem because if we have problems with cell reception, we can lose contact with our remote site in the middle of an assessment. And this actually happened to us last week. We were doing a vestibular assessment last Monday, and there was a thunderstorm in Peace River, and the bandwidth dropped to almost nothing. We were having like a 5 or 6 second delay of all sound. The screen kept freezing. We couldn't see anything. But we have really incredible clinicians. So even with all of that patchy stuff, we were still able to complete like a very basic assessment and a treatment. But I think that if we advocate for better rural services, like better internet or better cell coverage, that we would not see this sort of stuff happen again. And I think that this touches on a much broader topic of inequity in Alberta that maybe goes beyond the scope of this project. But I think it's something that we really need to consider as we move towards getting more equitable healthcare in Alberta, is what sort of other things do we need to change so that we can provide these services to people throughout the province. So we'll go to the next slide, Em.
Sorry, Emily doesn't want to go.
That's okay. All right, well, it's interesting how the goals of our project have changed. When we initially got our funding in January 2019 from Alberta Innovates and from Pfizer, one of our major goals was convincing people essentially that virtual health was a good option. But COVID sort of took that out of our hands. It made virtual health the only option for a really long time while the lockdown was in place. And it also meant that the whole world suddenly took virtual health seriously when there was a lot of reluctance towards it beforehand. And our small team never could have done this on our own. So it was really, really incredible to have this pushed forward in such an effective way. But it also kind of took the wind out of our sails for a little bit while we sort of went like, oh, now what? This advocacy piece was such a big part of what we were doing that we sort of felt lost without it. But then as we were sort of seeing the way that assessments were playing out, we noticed that what was happening was like not exactly what we were looking for, in that, you know, COVID meant that these types of virtual assessments were happening out of desperation. And the people who were organizing them didn't have the same like months and months of preparation time that we did. And so it meant that corners were getting cut and that clinicians were doing whatever they had to do in order to get the assessment to work because there was no other way to see their patients. But we want healthcare to be a valuable option and not just something that we do out of desperation. And that's why we decided to push forward with Tele-Rehab, because we really think that the protocols that we're developing and a program like ours will be able to keep that quality, and make sure that healthcare, that virtual health is just as important and just as valuable and just as good as in-person care. Next slide. If it'll listen this time. No, it's okay. Tech issues happen in webinars, and that's fine. We just roll with it. So with all that our project is doing right now, we still actually have a lot of room to grow. You know, we can explore improving the modules that we're already doing. We can explore new modules, and we've been looking at new modules for well over a year. We've been exploring opportunities to do stroke, pelvic health, sleep disorders, and a lot more. And we continually have clinicians reaching out to us asking if we can help them solve like this issue or that problem. So it's really clear to us that a program like ours is really, there's a strong need for it in remote communities and in rural communities in Alberta. And so even as our funding comes to an end on December 31st, we're still looking for ways that we can make a difference. And I want to thank all of you for joining us today, and hearing what we're about, because I really think that that's how we're going to be able to continue, is by having your interest and your belief in what we're doing. That's how we'll be able to keep helping rural Albertans to get this type of care. So thank you.
Awesome. Thank you so much, Emily. And so next we are going to be joined by Connie Brazel, who is a patient who participated in our project earlier this month. And she lives in Fairview, which is about 5.5 hours away from Edmonton, in good road conditions and no traffic and all those types of things. And so we wanted to invite her to talk today to tell you a little bit about her story and to see how offering virtual health services like Tele-Rehab 2.0 can directly impact real people in Alberta. So Connie, whenever you're ready.
Hi, I'm just to comment on Rachel's comment. Is there, who do we contact in Alberta Health Services to make sure that you guys keep the funding to do what you're doing? Because this program has been extremely beneficial to me, so I can imagine all the other people that it would. It's great. But I'll go back to what I was supposed to do. I fractured my arm in January, and it took about 7 weeks before I was out of cast, and I came to Peace River, which is still an hour away from Fairview. But I came to Peace River in the beginning of March, and then COVID hit, so we never got into the physio really until, I'm going to say, June sometime. I should have checked my dates, but I didn't. And with the injury in my right arm and the strain that it put on my left arm in May, my left arm became extremely painful too. So not only are they working on my right arm that was fractured, but now Judy, the specialist from Edmonton, called it an aging rotary cuff. So we're working on both shoulders at the same time. And it's made a terrible impact on my life because I can't garden, I can't go boating, sea-doing with my grandchildren. I can make jam. Emily is going to take my cat if I send her jam with it. I had to make that comment. Next slide, please. Rehab I'm still an hour away from Peace River, so in the dead of the winter, I sure won't be coming as often as what I had. So this rehab for me with the specialist in Edmonton is awesome because I get the benefit of my Rachel working with me weekly, and I get the benefit of a specialist. We're going to try for once a month for the first while. We'll see how it turns out. The time off of work to drive to Edmonton, the expense, the driving to Edmonton for a half an hour consultation, and then turn around and drive home and drive back for the actual whatever they're going to do. And it is painful to get into a vehicle when you're in pain already. To drive that far, you're right, it definitely knocks things out of whack and you don't know what's going on with your body. Next slide, please. This is convenient. It is really convenient for me to drive. I drive 50 minutes it takes me to get here. Over 5.5 hours to get to Edmonton, and not being able to find where you're going to in Edmonton. The hospital in Peace River is easy access. And the collaboration between the physiotherapists, the specialist, and our rural, I won't take anything away from the people that I've worked with in Peace River. She calls herself a general physiotherapist. I think that's what she said. But she has to be, because she is so far away from the city, and we can't have, in our small communities, we can't have one person doing this and one person doing that, because Alberta Services couldn't afford to have all those specialists in the rural Alberta. So this is fantastic for them to have this machine. What did you call it? Data. The Zoom thing that followed me around the room. I don't know what it's called. I'm not very good at this kind of stuff. But it was an extremely positive experience. I had a great time with Rachel and Judy and Emily on my first interview. Next slide, please. I've already said this. The collaboration between my physiotherapist and the specialist was fantastic. It's great for the patient, absolutely fantastic for the patient. Next one. And I really want to thank everybody for giving me the opportunity to be involved in this, because it has been a great benefit to me. And I think to Rachel too, my physiotherapist. So thank you very much. Bye.
Thank you, Connie, so much for sharing with us, for joining us and participating in our research and also our webinar. It's really awesome to hear from you. So next, I want to move on. I want to introduce Dan Timmermans, and he is a physiotherapist from Leading Edge Physiotherapy in Edmonton. And so he is what we are calling one of our hub clinicians. And so he began his practice as a physio in 2008, and he's completed training for vestibular assessments. And so he is going to join us. He's going to share his experience with virtual health and with Tele-Rehab 2.0 and his hopes for the future of virtual care.
Hi, guys. First off, thank you for all of you for joining us. I know that's maybe sunny where you are. It's maybe raining here in Edmonton, but it's an important topic, and I'm glad we get an opportunity to discuss it and share our experiences. Thanks for Martin and Emily and the rest of your guys' team for including me into the conversation with this project. I work with a group of physios here in Edmonton where we're striving to push into the community a little bit more. We like to be involved both with our practice, but also kind of on a non-for-profit basis to try to extend and using our skills to help the community in whatever way that we can. But also in the use of technology, we're always trying to find better ways and more efficient ways and cool technology and sort of the sharper things that we can include with our practice to make things more efficient and easier on patients. So when it comes to some of the vestibular work that we've been doing, and I'll get into that in a moment, but we get a chance to use some things that we wouldn't normally use in the clinic, especially not if we're not doing things virtually. come COVID time, us obviously being a physio in Alberta, we've had a mandate from the chief medical officer to close down to all non-essential and non-critical patients, which funny enough, a lot of the vestibular patients that I work with would have been considered critical anyway, so I would have had an opportunity to work with them. But it really limited who we could see in clinic for multiple reasons, but obviously everybody wants to stay safe and try to stop the spread of this thing. So obviously from a clinician perspective, we were happy to be keeping our distance, but we were really striving for ways to be able to reach out and make contact with our patients who either were ongoing patients in continuing care or some new patients in the community that were looking for solutions to their issues, but still kind of afraid to come out and still under quarantine. So Tele-Rehab, this would be a 1.0 if that's what you want to call it. Us as a leading edge sort of family developed our own protocols and our ways to sort of reach out. We were using a different technology besides Zoom, just for confidentiality and things like that. We found a really good medical technology that was helpful. But again, as Emily mentioned before, there's always things, right? So whether your patients are computer literate or not, and they might be really in need from an orthopedic or a vestibular perspective, but not know their way around the internet or not know how to sign forms and send them back without attaching this or that. And, okay, well, how do we get to these patients that might not even have an email address, but yet we want to meet, and I could talk to you on the phone, but then you can't see what I'm doing. So lots of these types of problems. The bandwidth issue was mentioned before. That's always a funny one because we get good at working like a robot and trying to hold the position just so that the computer can catch up and see what you're actually doing with the shoulder instead of going fast and having 30 seconds fit into 2. But obviously with this 2.0, it's been a little bit different. Our technology that we're using with this program is a bit of a step up from what I was using, not so much from the goggle side because we have that technology here in person, but obviously not virtually, so that was pretty nice. But we'll get into the kinetisense stuff, which I find really fascinating. For myself in the clinic that I do a lot of work on some chronic patients with vestibular problems, both from a concussion side and from a vestibular kind of end organ perspective. And I also work with an ear, nose, and throat physician here in the city where we do basically a multidisciplinary vestibular screening clinic. So somebody gets sick, they go to their family physician, they try some medicine or try some local physio, that doesn't help. So eventually they find their way to a specialist where the ENT will see them as well as me in the clinic, and we can try to find ways to see if rehab is still an option. Are there ways that we can kind of identify that they're missing parts to their rehab program? Sometimes they're just missing that BPPV, but they've been sitting now for 8 months, and it looks a little bit different than it would if you caught it in day 5 or day 10. And my physician colleague has mentioned to me that there's a lack of, and I don't want to get too much into it, but one of the vestibular reflexes that we deal with is the vestibulospinal reflex. So this is what's going to affect our balance quite a bit. So there's a lack of kind of evidence and clinical work in the community based on this VSR. So we use the ocular part. We use goggles quite a bit, and most vestibular physios, if you go to them, they'll know about the eyes. You can do a maneuver and you can see the nystagmus, and that's pretty common. But that's almost where it stops. If you can't find a problem there, but yet the patient is still saying that they're dizzy, there aren't really options to go beyond that. And in this project that we're working with Tele-Rehab 2.0, we get the privilege to work with the kinetisense, which in a way is a look. It's not a full picture that you might get at the Glenrose, but you can take a look at that, some of the reactions from the vestibulospinal reflex, and see how their sway is affected when they're closing their eyes or if they're on a compliant surface, more than just the indirect sort of viewing. So it's been kind of nice to be able to have that, and you get an instant graph as it goes. That's all real time, so you can slow it down, you can video it, so you can kind of take a look and see how their balance is responding in different ways, which has been kind of nice. I mentioned this to my physician that I work with, and she's really excited because she as well is involved in the technology, and she teaches at the U of A. But she mentioned trying to get into some of this VSR research. there's one place in the city of Edmonton, outside the Glenrose, that you might have some access to this. And while it's good and it's really, kind of a cool technology to use, it's not very accessible, for our patients that are going to wait a year and then they get into the Glenrose and they might get that assessment, or it might not, it's not necessarily the most practical when it comes to treatment, especially, or assessment. So that's been kind of nice. So maybe let's kind of look at it. We have a video here, just kind of help explaining a little bit more about what this Kinetisense is and why I'm kind of excited. I am a bit of a nerd when it comes to this tech stuff. But Emily, if you have, we took a video of Martin. Martin was gracious enough to be a patient of ours so that we could just get an example of what this looks like. So here's technically it's not quite a Romberg because his arms aren't crossed, but here he is trying to maintain his balance. He's got his eyes open. And if you look pretty close, you can see that it'll show your head tilt left and right, your head tilt anterior, posterior, from the shoulders and from the hips. It gives you a good idea about what he's doing while he's trying to keep his balance. And here he is in the same position with his eyes closed. It's hard to see without the split screen, so we did another video after this, so I'll explain that. But if you look on the right side, you can kind of see, if you look closely, it's a bit grainy, but it'll show on the graph where his head, where his shoulders, where his hips are. And it seems pretty similar, but if you look at it side by side, you can really see him pulling towards the left side of the screen, which is his right side, and anteriorly. He does it a lot more with his eyes closed than his eyes open. So from a vestibular perspective, this makes sense. If you're having a hard time with your vestibular system and you take your vision away, obviously you're going to work a little bit harder at it, but it's more than just, oh, he has a bit of sway. Like the traditional data collection of this Romberg test is literally a 1, 2, 3, or 4. 1 is it normal, 2 he has mild to moderate sway, 3 is severe sway, and 4 is he fell. So where does that fit in, right? Oh, maybe he had I'd call it a 2, so he had a little bit of difficulty with his eyes closed versus a 1 with his eyes open. But does that compare with someone who doesn't have a vestibular condition or has had this type of vestibular condition or a positional vertigo problem, and how does that relate? As far as I know, they haven't done that research yet. So when we start looking at this, I know it's not really the aim of the project, but it shows us that it can, right? And we can use something that has more objective quality to it. So not only from obviously from like a WCB or an MVA perspective, where they're really looking at objective evidence to, is there an injury there? How bad is this impact? As well as is it getting better with treatment? But we can be a little bit more accurate, especially from a distance. So when I first started with Tele-Rehab 1.0, obviously we need our objective signs. We need to kind of look for ways that we can mark our improvement. But this is one way that it can be really, quite objective, and we can compare and we can save this data and look over time. So that's going to be a really powerful tool, I think, going forward. And I know my ENT colleagues are really excited about it too. The other aspect that we do, and again, I do this in clinic. This was my first opportunity to use, from a vestibular perspective, to use these infrared light goggles. So using this technology, it's really helpful in the diagnosis and the treatment side of what we would do for a positional vertigo. And for those of you that aren't in the area or might not know what a vestibular or a positional vertigo is, it's basically like you're getting a mixed signal from the inner ear. So you lie down, let's say for instance, someone might have a positional vertigo on their left side. They lie down in bed, all of a sudden they feel like their world is turning and that bed is either flipping on them or rolling on them. And it's a pretty common experience. Most people that have vertigo problems tend to have this positional vertigo type of issue. But it really does, the system on the right side says, well, I'm lying down, I've got my head to the left, everything is fine. And the system on the left is saying, no, we're doing flips. So the body's going to believe the worst case scenario, obviously, and you have the associated response, which sometimes is, yeah, you're screaming out and you're reaching for each other, trying to find some stability. But worse than that, if you're getting sick or nauseous and throwing up and you're scaring your spouse, which is probably the worst part of it, right? No one knows what's going on. You might end up in the hospital thinking you're having a stroke, which is not a great use of our healthcare facilities. But with the use of this technology, It helps us with our assessment and helps us identify good treatment options, because the treatment of a positional vertigo will depend on where this problem is, which side it is, instead of just picking and choosing. With Tele-Rehab 1.0, I was doing some of this during COVID time, but where I was really concerned, a couple different ways. Number one, I didn't have goggles that I could just give to patients and they could work with them at home. So that's obviously a challenge. Sometimes people would try, for my patients that I've been seeing for a while that knew what their symptoms were like and I knew what their response was like, would hold an iPad over their eyes or hold the camera there so that I could kind of see it while they were doing it, which was effective actually. I could kind of see enough of what I needed to do, but it's not quite the same as being blocked off in an infrared light goggles setting where the patient actually doesn't see anything at all. But the other thing is a safety concern. These guys, you know, if I knew they had a positional vertigo, that might be where it ends. And my suggestion was, okay, well, we know you have this problem, but honestly, I don't know how you're going to respond, and I'm not there to save you. So if you have this problem and all of a sudden you have a vasovagal response or you're falling over, I can't help you. Your wife isn't strong enough to pick you up off the floor, Mr. Jones. So now, how do we deal with this problem, and how do we best manage your condition so that you're comfortable and you can hold off until at least you can get it in person, or maybe the conditions would be lifted a little bit so that I can see you in person and not have this such a nuisance. But having the goggles at the far side, it's really quite nice. I also, by the way, I don't know if I thanked Rachel and Rochelle enough, and if I haven't, let's keep talking about them, because they are, you know, from an expertise perspective, I've been doing this a long time, and now I'm asking them to be my hands and my ears and my face kind of over there remotely while I'm here in the clinic in Edmonton. So seeing, specifically I was working with Rachel, who I don't know if she's joining us right now, but her learning curve where she started, she didn't have a lot of vestibular experience. She was really eager to see what we did, but went through the roof. We, you know, even in the first and second assessment, she really kind of grabbed on. And I know she's been putting a lot of work on the side to kind of do it. So thank you guys very much. Pass that on to Rachel if he's here. Now I'm lost. I can't remember what we're talking about. Let's take a look at the vestibular goggles. Do you have that, Emily? So these things are sweet. I tell my patients when we put them on, it's the most expensive blindfold you're ever going to see. So just pause it for a sec. Don't do it yet. This patient, so they're sitting on the plinth. Rachel's got them nice and supported. So there again, like I feel a lot more comfortable having Rachel there. We can do this maneuver and she's doing it for me, but I'm looking through the double. I can see what she's actually doing. So I can see her and the patient. And then through Zoom, I'm looking at the screen, monitoring what the eye nystagmus pattern is. So nystagmus is an involuntary eye movement, so this patient isn't trying to do this, but it's a response to what's happening in the vestibular system. So as you'll see, this patient basically lies on his back, and he feels like he's doing backflips. If I wanted to get my eyes to do this, I could. I'd have to blindfold myself or put these goggles on so I can't see anything, and then do backflips at a pretty rapid rate in order to get my eyes to do this. So take a look. If you're new to vestibular rehab and you haven't seen it, this is quite fun. I don't know if you have sound or not, probably not, but yeah, this guy's, so there. So generally speaking, the nystagmus pattern for positional vertigo is going to be pretty rampant within the first few seconds when they lie down. And then as the material that's causing the response settles down to the most gravity dependent position, it'll stop. So that was a quick blip, but in reality, this man felt really dizzy for about 10 to 15 seconds. Then he's like, oh, okay, I'm better now. And then you go through the maneuver and it'll help him kind of restore his ability. So good thing about this study is we get a chance to reach out to these guys. They wouldn't have access necessarily to a vestibular therapist up there. And, you know, when Connie was mentioning how hard it is to come over with a shoulder problem, it's really tough for a vestibular patient to drive 7 hours when driving 10 minutes makes them feel like they want to throw up. So, you know, lots of these patients, when they come and see me in the clinic, are coming in a wheelbarrow, and their husbands or their wives are really kind of dragging them in, and we can get them moving and get them feeling better. But it's different if you're 7 hours away. So we get an opportunity to follow up with this guy, I always give them my contact information. So if they're really struggling after the assessment, or if we want to see them again, we'll find a way to get them into the hospital again. So that's a beauty of this rehab project as well. We have the flexibility to be able to kind of have them back in and do a reevaluation or another treatment if that's going to help them kind of get through. But at the same time, we're taking down information and determining whether or not we're effective at what we're doing for kind of clinical side and from a diagnosis side. So I don't know, I guess that's what we do. I could probably talk for 10 hours about this, but I don't think anyone wants to hear it anymore. So if you guys have questions, definitely let me know. But thanks for allowing me to share.
Yeah. Thank you so much, Dan. We're so lucky and so glad to have you as part of our team. So before we move on to our next speaker, I'm going to read something one of our rural clinicians sent me to read to all of you about the value that she found in the project. So this is from Rachel, who is, Dan mentioned her. She's a physiotherapist from Peace River, and she couldn't attend tonight, but she says, since participating in the Tele-Rehab 2.0 project, I have gained more confidence in initiating and carrying out virtual care. For example, I've been working with a patient who had tendon repairs in his hands, and we had been plateauing in range of motion. My patient did not want to travel to Grand Prairie for a specialist assessment, so I reached out to the hand clinic in Grand Prairie. I was able to set up a virtual assessment with one of the hand physiotherapists. It was extremely helpful, and I got a lot of new ideas of where to go with the treatment. Tele-Rehab 2.0 helped me to show the value of reaching out to specialists and that virtual care can be delivered in an effective and meaningful way. So that's really nice and really exciting to hear from her. But next, I'm going to introduce kind of her counterpart, also with a similar name, is Rochelle Lawrence, and she's another physiotherapist from Peace River. And she graduated about 4 years ago from the University of Alberta with her master's in physiotherapy. And she's been working in Peace River ever since. And so kind of, I think Connie mentioned it about how she's a generalist. With most rural clinicians, they have experience with a wide range of conditions and works really hard to make sure she gives her patients the best care possible. So she's one of our remote clinicians, and then she's going to talk just about her experience as a rural physio and what telehealth and tele-rehab have been like for her so far. So just unmute her, and then I'll share her slides. Okay. Okay. There you go, Rochelle.
Awesome, thank you. And I want to thank the Tele-Rehab team for the opportunity to share my experiences so far with their project, and then just to discuss a little bit my background and then the value that I've seen so far with virtual rehab, really improving care in our rural communities. Next slide. So as Emily mentioned, I went to the U of A, but I was at one of the satellite campuses at Augustana. So being at a satellite campus, we had a bit of a focus on the program, one about kind of rural experiences and talking a lot about trying to get more clinicians into the rural communities in Alberta. And we also had a lot of exposure to virtual teaching approaches and interactions with technologies. We also had a robot in class sometime and had a lot of video and screen time with professors in Edmonton. So I think that experience a little bit kind of has definitely helped set up for some good success, both with COVID and then also with this project. While I was doing my degree, I had a couple placements rurally. One was in Jasper, one was in Beaver Lodge, both pretty small communities, both fairly far away from Edmonton. And those were kind of the first times where I was really encouraged to kind of, expand my thinking about, how do we provide care to all clients? How do we reach out to them, and what does client-centered care really mean, more than just that catchy phrase that the profs like to kind of throw around to you and AHS likes to talk about. So really starting to think about, how are our clients coping in their home communities, clients who may be elderly or don't have a lot of family support locally. clients who've moved into facilities. How do we get them care? And it quickly became apparent that, there's a lot of clients that just have a really hard time accessing those higher level of cares in rural communities. I had also, I was one of the few kids apparently in my class who thought that quality improvement was a worthwhile class in our degree. And it really had me kind of thinking about how do we, make care pathways a little bit more straightforward for clients, and what's our role as physios to help with wayfinding in our healthcare system so that it's a bit more of a direct process for clients and there's less of those kind of, referral forms back and forth, and, clients never really know where they are in the system. So at the end of my degree, I was offered a job up here in Peace River at the health center, 6 hours north of Camrose. I'd never been up to Peace River before. I had a Skype interview and I accepted the job, and I didn't really know what I was going to learn when I came up here, but 3.5 years later, I've got to work quite a lot in our acute care here. I've worked in a couple of long-term care facilities. I do a lot of pediatric work. I've done some stroke care, and currently I'm back in outpatient orthopedics role. And yeah, like we've kind of discussed, you're kind of sometimes that jack of all trades generalist, and there's a lot of days where, you're doing a lot of self-study and trying to figure out, how you're going to help support this client a little bit better. So a colleague I used to work with, she was at a class reunion and ran into Judy, and she had mentioned that she was involved with this Tele-Rehab project, and they were thinking about Peace River but didn't really know any of the clinicians here, so she kind of encouraged me to reach out. So found the website and I got in touch with Emily Armstrong, and yeah, we kind of have been really excited in Peace River about being part of this project. So next slide. So I think as a rural clinician, one of the things that I'm really excited about with this project is these really strong opportunities for mentorship for clinicians in rural communities, especially for new grads. There's 3 physios in Peace River right now. We're all, I've been working the longest. Rachel and Courtney, my other colleagues, are even, fresher to the scene here than me. So we're all taking on new caseloads, all learning a lot of things. And, there's days where I also feel like I don't have a lot of capacity to support and help mentor them too. So it's really exciting to know that, this project allows us to reach out to, clinicians like Dan and get a lot of support on these, a little bit more complex topics that maybe we haven't, seen since we were in school, haven't really practiced clinically. So, it's really taken a lot of that kind of stress off in terms of, always having to self-study and try it out on a client for the first time and hope that it goes right and, not necessarily be really confident with it. So kind of like Rachel had mentioned, the mentorship from this project has given me as well a lot more confidence in terms of, thinking about, are we on the right track, and how do we, set goals that will work with the clients really well. Before this project, when I was looking for mentorship, I'd reach out to my North Zone, clinical lead, and that was helpful, but, they're helping out a lot of different clinicians, talking to my preceptors or, other clinicians that maybe have referred me clients, from the Glen Rose or different facilities, kind of trying to catch up with them. But if you've never really met them and you don't have that face-to-face connection, it's really hard to, feel comfortable always calling them or sending them emails and, not really wanting to feel like a bother all the time. So it's really exciting kind of having this really, collaborative, we're both on the same page, we're both willing to kind of, put that extra time in and interact with everyone a bit more readily. So this project has made a huge difference for that in terms of, making it a little bit more straightforward in terms of accessing the specialists, and then being able to really connect our clients to those specialists as well, and not just saying, hey, I'm going to send a paper off to somewhere and I hope a specialist gets in touch with us. It's a lot nicer being able to say, I know this great physio in Edmonton. I think, he's really going to be able to help us out with, your vertigo or your balance or any of those types of things. And to have a face with the name, I think that's been really, really nice. So I think it has a lot more strength than me just writing a letter and, sending it off with my client as the mule to the surgeon, like, hey, these are my concerns. you don't really know what I know or what I've really seen with them, you know, in the last 6 months. So when we can kind of face to face, I had a great one this week with Judy where she was like, you know, what have you been doing with this client for the last 6 months, and what do you think's going on, and how do we kind of bring that all together? So it's been really nice having that, you know, support for those more complex patients with the kind of enhanced mentorship of this project. All right, next slide. So, you know, in the last 3 years, working with clients in a lot of different disciplines, kind of like, you know, Connie mentioned, you know, how do we get AHS to kind of hear about it and support projects like this? I hear a ton of frustration about, yeah, the cost of traveling out of area. Often clients are gone for, you know, 2 or 3 days, go down the night before, have a hotel, have their appointment. They often try and book it in the morning, but if that doesn't work and they have an afternoon appointment, they often spend another night and then are driving back to Peace River the next day. Some of my pediatric clients who are kind of involved with complex teams in the city, often they have 3 or 4 days of assessments at the Glen Rose with all the different teams. So, you know, it sometimes means that they miss out on a whole week of treatment up here with us because they're gone that entire week, or they come back from the city and they're just wiped, and, you know, we end up waiting a whole week until we can follow up with them again. So, you know, like has been mentioned, that discomfort of long vehicle rides, you know, a lot of pain with hip or knee replacements to sit in one place. So, you know, I think this has been really great being part of the hip and knee module in terms of, you know, not yet being able to replace those visits, but just showing that potential for having clients just come in here for their 6 or 3 month follow-up appointments, and really saving that trip to the visit. Trip to the city, and like Connie mentioned, often a really short visit with the specialist in terms of the amount of time that they spend traveling. I've had a lot of clients say that, you know, the surgeon just breezed in, said hi to me, asked if everything was feeling good, if I had any questions. If I said no, they're like, okay, yeah, I'm happy with your x-rays, and they like head out again. So I've definitely heard a lot of clients come back after those visits and just kind of tell me like, you know, I don't know if that was really worthwhile. And they often ask me, you know, what's it going to be like, or what should I be expecting? And yeah, it's not always great to kind of tell them that, or, you know, you kind of want to be realistic, but you also don't want to really set them up for that kind of not necessarily the most positive experience. So I think it's exciting to kind of have options like this where, you know, we can really minimize that. In terms of that busyness as well, you know, clients often tell me they didn't really have time to get their questions answered. I often encourage them to like write them down on a sheet of paper so that they have them right there and can say like, hey, this is my concern. And I think so far we've seen with this project that clients have a lot of opportunity and a lot of space to ask the hub clinician a question and have time to have those discussions and have really meaningful conversations about kind of what their biggest concerns are that maybe aren't just range of motion, right? It's, can I get down on my knees and garden after this operation? Or when can I climb up into my, you know, big truck again? Because, hey, I still have my class 1 license and that's really important to me. So I think that's been a really meaningful experience with this as well. Another thing is, you know, the multiple providers. Clients have the same conversations with me, and then with the bone and joint clinic, and then with the surgeon, and then maybe with their family doctor. And, you know, if we can kind of use this virtual room and have that conversation with 3 of the providers in one space, I think clients really appreciate not having to repeat the same conversations and keep track of each provider and what are they telling them, and, you know, why am I repeating this for the 3rd or the 4th time? So having that face-to-face interaction with Tele-Rehab like 2.0, I think, you know, really makes it a lot less confusing for clients and kind of helps bring it all together. And I think Dan or someone had mentioned this too about, you know, there's a familiar face in the room with them. Here in Peace River, you know, often we've been working together for maybe 1 or 2 months before, say, some of these 6-week or, you know, 2-3 month follow-ups. So it's nice to be in the room with them and, you know, kind of explain to them what's going on. And then additionally, you know, after the assessment, I can talk to them and kind of, if there was anything that they didn't have a chance to ask or anything that they're confused about, we can go over, you know, what they maybe missed out on and clarify anything that didn't make sense. You know, kind of more generally with virtual health in the last few months with COVID, I've definitely seen a lot of improvements in terms of discharge process. I've had a few really complex kids come back to Peace River community from the Glenrose, and it's been really exciting to see the Glenrose team, reaching out to us. We had a couple Zoom discharge meetings before they even left. We had the pediatrician was present, the respiratory therapist, the home care nurse, and we were able to connect with the whole team here and talk about, how do we get the supports in place in Peace River, and if we need to reach out, who are the people we can reach out to in the city. And I think, we didn't have video in that situation. It was kind of just an audio call, but I do think there could be benefit potentially in the future of, having the family, in the room too for that, or, actually being able to meet the client ahead of time, because some of these meetings before they actually come home, and it's hard to kind of know exactly, we've maybe never seen someone with this type of injury in Peace River before, and it's nice to kind of have a little bit of that lead time to kind of prepare, for a new admission into the community, and to actually kind of have a face and, know exactly where that client kind of is and what their big supports will be. And, I think the potential of the 2.0 level of Tele-Rehab to really improve that connection, I think we're on the right track with some of the advances here, and even in the last couple months. But I think there's a lot of opportunity kind of beyond this project to kind of implement that, like Emily mentioned, into lots of other different modules and different aspects of our healthcare system. Yeah, I think next slide, please, Emily. So yeah, as I've kind of been discussing virtual health, I've been, kind of interested in since school. I did the U of A course that Dan Gillespie had offered this spring, just as I knew that, Zoom was kind of rolling out. Our clinical lead was really encouraging in the North Zone here about, implementing Zoom and becoming confident kind of with it. He'd done a bit of teaching kind of and some practice courses, which was really nice. And then, I took that course, just helped me kind of see a little bit more kind of the history of really how long virtual health has been around. But it does seem really like in the last year, there's been a pretty big jump in terms of, what we've been able to offer compared to what's, maybe been going on in the last 5 or 10 years. So kind of, we saw some good stroke projects there and some really cool outreach projects in some rural communities. And I think I was really encouraged by that to, see Peace River kind of fit into that model and kind of, figure out how we can make that work in communities here as well. So currently with COVID restrictions, about 50% of my kind of patient visits are through Zoom or via phone. I definitely am preferring to use Zoom as much as I can. I really find, being able to see the patients, really ask them to do some movements or maybe show me stuff really helps them be a bit more engaged. Often I have a hard time kind of coaxing much out of some of my patients on the phone. It's like, hey, how have you been doing? Oh, I'm good. Yeah, okay, that's fine. Talk to you next week, or maybe not for a month kind of thing, right? So Zoom has really made it a lot more, interactive in terms of I can see them, I can kind of engage. It's been really exciting kind of see some of my clients become a lot more creative and, tell me the things that they've set up in their house, or, I found this box or something, and I had my husband build me this so that I could practice my step ups for my knee program. And my neighbor's been coming over with me because we've been working on walking more distance, but I wanted someone to come with me. And even just getting to meet those support people that are with them, with COVID, they're not allowed to come into the hospital with us, but if I can do the Zoom appointment over the technology, then I can meet the family, I can meet the kids or the neighbor, whoever's able to help out and, give them some coaching or have them, maybe help with an exercise or setup. So I think that's been, really exciting for the patients to have more opportunities and more options to try that kind of stuff out. Peace River Hospital has a pretty big catchment area. So like Connie mentioned, some of the clients that we're seeing are traveling an hour or more to come and see us here in Peace River. So if we can minimize the amounts of times that they have to actually make that physical visit to Peace River, and maybe, every other visit we can do through Zoom. I have a we've been able to use our assistants, or, maybe my OT colleague can be in the home or the facility, and then I can kind of walk them through what I want to see and, use the video to provide some feedback. And I think, you know, being able to tie in some of those recordings from Kinetisense and having more of these technologies kind of set up moving forward would be really exciting in terms of, you know, maximizing therapist time, kind of reducing travel, because, you know, like Connie mentioned, you know, we can't have enough therapists really even in these rural communities. Our wait lists are pretty long up here in Peace River, and, you know, any strategy that we could use to increase the amount of clients that we can work with and, you know, making the best use of our time is really exciting. So next slide. So yeah, you know, Tele-Rehab 2.0 for me in Peace River, you know, I've really valued the collaborative team approach, you know, working with the therapists at Leading Edge and Emily and Judy. You know, it's been really exciting to see how encouraging, you know, they've been of helping us kind of develop our skills. Emily mentioned the really kind of boring outcome measure that we use at the start of all of our assessments, the COPM. And you know, as much as it is a little bit tedious, I do think it fits really well with this project in terms of being really client-centered and really ensuring that we have a good understanding of our client just beyond kind of that injury. And, you know, I think even for me, some of the questions we've gone through with the COPM, I've learned things about my clients that I've been working with for, you know, say 4 months that they had never shared with me that kind of came out as we were kind of digging through that COPM. And I think I'm really excited about, you know, gaining a bit of better understanding of my clients and making sure that we are working towards those really functional, important lifestyle goals. You know, having the hub clinician expertise and, you know, that 20 or 10 years of experience, I think really goes a long way in terms of saying, you know, this is a realistic goal, or, you know, this is what I think we can say about your prognosis, you know, based on the 2,000 hip or knee replacements that they've maybe had the opportunity to work with, or the vast experience of, you know, vestibular cases they've seen. And it definitely helps, you know, me feel like we're giving them a really, you know, realistic idea of where we're heading with this. And, you know, not just me trying to kind of think about what I've seen in the last 6 months or the last 3 years and say, this is where I think we're headed. So, you know, like Rachel mentioned, I definitely feel like it's given me a lot more kind of confidence